going to get started. There's stuff in law students may be running late or may not be able to make the meeting at all. So it's so nice to see everybody in person and put a face to a name. And thank you so much for coming in. And Tracy, can you hear us?
All I hear is garbled. I think Barbara was talking.
Speak now with Tracy.
Are we speaking through you, Peter?
Oh, I could hear Tony Ann then.
I don't know. I can have her. I can have her unmute on mine. That's like, and then
Sure.
Whenever. Figure it out. If the audio is all on. Tracy, can you talk right now?
Somewhat.
Okay, so we can hear you on mine, but we can't hear you on the.
I have mine turned up as high as it'll go too.
Okay. Well, what?
Okay.
I guess I'll just ask you to all pretend that you're in a speaking contest and you speak as clearly as possible.
Okay, as long as we're not, is it echoing?
Go ahead, don't hold the meeting up.
Okay, no, we'll go ahead. So we were just saying it's so nice to see everybody in person and you, Tracy, but we still can't see your face. We saw it for a second, but you'll be back on, I'm sure. I think we have gained a lot of ground on figuring out what some of the obstacles are and barriers are to providing care. I actually spoke with, I sit on the, the coalition.
The Connecticut Pediatric,
Coalition. And I spoke about what we were potentially working on and how we were building this. And I spoke a little bit as if we were building from the ground up. And I think we got a lot of positive feedback on always go for what you see as being needed, and then the work comes on the back end with what can actually happen, what can't happen, but we've been asked to recommend how we think we can get there providing pediatric hospice in the state of Connecticut. So I'm glad that that's the direction we're going in, because it seems to be, pretty much, acceptable when we talk to a lot of different people. All right, we can, hopefully that can happen. What we did pass around, and Tracy, you know what, I'm gonna send it to you right now, was something that Melissa worked on late last night, so we didn't have it. Give me 1 second and I'll send it to you. It's not on you.
You can hear us, but we can't hear her.
Okay. I'm gonna go ask her to put the microphone on here. I'm not an IT person.
Right here.
Brian might know. Brian, in your house?
Oh, yeah. I can't see.
Hey, Brian.
Can you talk after this?
Tracy, if you can hear us, I just sent you the presentation that we're gonna, look at some point today. But Melissa and I were also talking about, since we're getting close to March, and I think a question for us also is, being a newbie to this, how does this get presented in March? Like, what does that look like? And is it a written document? Is it like, what is the format of presenting this in March? Does anybody around the table know that? Or Tracy, are you familiar with how the task force presents the recommendation?
Well, others can chime in, but I can tell you I've been on 2 work groups besides this one, and am actively part of the safety work group right now, which Peter, while he's sitting there, has just received an email with our draft report. It's the 2 groups that I sat on, the 2 groups that I've sat on are we go through a summary, we go through, we list the work group members, the task, all the, you talked before about challenges, concerns that have come forward. We list those are the things that have been discussed, and then we put in the recommendation.
We studied put allergies in schools, in the school system. So we did come up with a document, a written document of, what we did, what we found, and then in addition to that, we had a in-person presentation.
Okay. So Peter, you'll send the template of the document, okay. And Tracy, just so you know, if you can hear us, we can't hear you, so we're trying to get that fixed. Well, we can hear you somewhat, we need to like fix it in the room, so hopefully we can get that done. I don't think it's on your end.
It's on our end.
Yeah, it's definitely on our end that we're not hearing. So Melissa and I were like thinking about, okay, where we're at and how we proceed forward, but actually asking the questions. Like, right, we've been asked to review existing hospice services for pediatric patients across the state, which I think we've been doing ad nauseum, right, in a way. Making a recommendation for appropriate levels of hospice services for pediatric patients across the state. Oh, she's saying she has no chat function.
We removed, the CBA removed that option due to FOI. So that's why.
Jasmine is now attempting.
Oh, well, yeah,
I have the superhero IT.
Tracy?
Yeah.
Can you hear us?
No, she can hear us, but
So, can you hear her on your end?
Yep. She starts speaking.
Can you talk, Tracy?
Yes, I can talk, Barbara. Been talking too much today.
That's his own.
That's fine. The microphone's working, is it not coming in through the?
Yeah.
It might be because you're connected there. You might have to plug that into here to hear the speakers, or
Yes, my account.
sure. No. Okay, so who's connected to this screen?
Me.
Okay, connect to your.
I actually connected through the buttons, the remote, and I did it through here. It's on my account, so it's Cascade.
Can you speak Tracy?
Hi, Tracy.
Testing 1, 2, 3.
Oh, that's great. Oh, wait, this is his freeze, nothing. Okay.
So
Okay, so, oh, and,
I just
thank
should
you.
open.
No, we just, we just send it. Must have heard me screaming from my house yesterday.
What if I also connected to my tablet and put it up there?
I think it's
Oh,
or
yeah. The other option is to just look at the years that you can use for.
do you have a test one more time? Can you test Tracy one more time?
Tracy, I.
Yep.
Oh.
Test, test, test. I'll just do it through mine, but yeah, test, test,
Test, test.
Yeah, so it's not
test, test.
secret, it's not working. Try.
I'm on that one X. So I'm connecting to the internet.
Barbara and just speaking to you.
Yeah.
Is that okay? Yeah, meet Barbara's and we'll speak with Peters, maybe?
We have to move it forward.
Okay,
Can you hear us?
Yes.
okay, let's do that.
I'm-
All right, we did a workaround.
So you can hear me now?
You can, and I'm gonna come out, I'm gonna turn mine off. All right, there we go.
Okay, all right, so Tracy, so just to catch you up, Peter said he was gonna send a template to Melissa about how this gets presented or written up, but did you want to say maybe what you said before when we couldn't hear you about how this gets, what kind of format?
Well, I didn't get a template. So I went by a work group that I was on a couple of years ago and used that as my template. But I basically see what Peter shares, and if he wants to kind of share the template that we, or the, maybe not the content of our safety work group report, but how it's set up. And I'm sure Brian, I can see him in there. Brian and CHA, I'm sure, have worked on many a report. So I'm guessing that they would have guidance as to what to do. But we just made sure that there was a summary of the meetings, as well as the challenges and concerns that were raised. And then the work group members and the recommendations.
Because that's like citing the enabling statute that.
Yeah, and we put the statute in too, Brian, yeah.
Right.
With a little summary of what the work group's tasked with.
Right.
Addressing any concerns that they had in the session.
Right, okay, which is kind of what you had, you're looking at this again on, Melissa and I were talking about, like, we were asked to review existing hospice services for pediatric patients, check. Working recommendations for appropriate level of service for pediatric patients across the state, I'm sorry, making recommendations. And evaluating payment and funding options for pediatric hospice care. So I think as far as, do we have sufficient information, right, to meet the goal of, we have reviewed it, I think we have sufficient information for that. The survey would be whenever the survey
I have
comes
8
back.
responses so far,
Okay,
so I'll start making phone calls. as well.
okay. How many were
We have-
on?
We have 88 home care
88,
providers.
and we have 8 responses.
But we had a little glitch, so Karen and Michelle were very, very helpful. They were,
Good.
field testers. So we worked out the bugs. I'll do another blast facts reminder for those that have not, for the 86 or whatever that have not. And, I think we really, to the extent possible, we want to have 100%. So that we really know what we have. And then I've also, both with our GIS mapping. So we will take that data, put it on a Connecticut map, and then we can see where the home care agencies are. So I'm envisioning, we'll place the home care agencies geographically on the map. And then we'll give home care agencies, of the 88, 24 provide hospice services. So we'll have a legend for what the colored dots mean. So if you are home care and hospice, you'll be one color.
Mhm.
And then if you're home care, hospice, and provide pediatric services, you'll be another color dot.
Okay,
So this way we can see geographically what it looks like for service delivery.
okay,
And then we'll be able to identify, we know there's lots of gaps across the state.
okay. So, but if you're also just hospice, will you be identified? Just hospice.
So no one, we can do that, but you cannot be hospice unless you're a freestanding.
Okay,
So you cannot be a community hospice provider unless you're a licensed home care agent.
okay, gotcha.
So that's why I would juxtapose that color differently.
Okay,
And then the other questions we asked were, last time you did it, Jasmine, you asked about geographical locations.
Mhm.
And then there was another suggestion about medically, I think Tracy asked about medically complex.
right.
So I'll see if anyone can help me at DPH, or if anyone on the group would like to help and remind home care agencies, we sent a survey, can you please repeat?
Sure. Okay, and then you know, obviously, who responded and then who didn't, and you could reach out to ones that specifically
Yes. Yes,
didn't
that's what
respond.
we'll do.
Okay,
May I make a suggestion?
yeah,
And I'm sorry, I know I suggested something prior to the survey going out, but Barbara, the putting them on the map like that, I understand your thought process, but will that capture if, like, Vitas has multiple offices
No,
and service area? So, regional may be in Danbury, but they have a service area that covers, so it's,
so I can look at, so let me contemplate that. And look at, there was a response question about locations,
yeah.
and let me see the corollary there.
Okay, and then the only other thing I would do, I just reread the blast facts. I think it would be, if you're going to send out another one, I think it would be very helpful if you put something, I know it says that it was tasked with licensed home health agencies, but it would be helpful if it says in there, whether you're home health only, home health and hospice, we need you all to participate in this survey. Yeah, something to just encourage, because I don't think it's really clear. They probably see pediatric hospice and just respond if that's all they,
Nope, we could add that. There is I think there was a sentence though that indicated that this is going to help inform decision-making and please respond, but we can absolutely add that.
okay. Perfect, so that'll be good for us, to know also. On the cover, page 1, page 2, that Melissa put together kind of gives us the same exact thing, right? What is the mandate? And then, the requested report is due on March 1st. And I'm sure that since it's due on March 1st, that's a held firm for March 1st, which is fine. The only thing that I wanted to get out of the way and after we meet today is that it might be good if we can meet twice in February as a work group, because what I'd like to do before our next meeting in February is you can see a lot of what Melissa has put through just by the minutes of our meetings and you know, how far we actually have come, but there's been a lot of behind the scenes kind of work on data. And so, and I want data obviously to go in part of this report. And I think, and I don't want to like sound like this has been easy, but I think the recommendation is basically going to be a real true recommendation of what it needs to look like to provide hospice to children in the state of Connecticut. And it's go for, you know, I said on the coalition, it's like, we're going for Oz here. And it's somebody's job to build the yellow brick road and get us there. But I think it needs to look like exactly what we want it to look like. And I did want to bring up one thing, because we've been working a lot towards how do we provide hospice to children in the state of Connecticut. And that has been mostly at home. We've been going on the idea that most families want to be home with their children. I only know that from a hospice facility perspective, meaning we have a hospice facility. It's a 12-suite facility. We have tons of adults that come to die there. We have a lot of our adult population that are on home hospice, but will come to the center just for end of life. Like we know they're starting to transition. They want to come into the center. They want to die in the facility. Some, as soon as they get a prognosis of 6 months or less, want to come to the facility. It's all different, you know, things for adults. However, for children, we have been open for 10 years. We have serviced 11 children in the facility over 10 years. We've had 11 children die in the center. So for us, those kids are on home hospice and they never really end up coming to the center. They all die at home except for, you know, these 10 or 11. Mm-hmm. And I might add, 5 of them came to the center for respite, for caregiver fatigue, and happened to die while they were in the center on respite. So that too, they weren't coming to die, they were coming so the caregiver could have rest. And it's, you know, in all cases, it was just amazing to watch the parents either go to sleep or leave and go to the hotel across the street, and the baby just go right into transition and pass. So that's what we've been seeing. So, you know, in my experience and what I've been talking to a lot of with pediatricians is, yes, the babies want to die at home. We had the privilege of taking care of a 2-week-old. I was talking about it before, that was referred to us from Montefiore. Insurance denied them coming to the center. So the parents have decided to take the baby home. But while we thought we were taking her to the center, we needed to put a, you know, email out about, are there any family practitioners out there that could help? Because the baby was going to have to be seen on a daily basis, and we were going to have 24/7 coverage because our APRNs that cover, we only have one family practitioner. A lot of people responded, which was great to help, and Kristen being one of them, she was amazing. But one was Dr. Wolf Gruber from Connecticut Children's. She's the head of the hospitalists at Connecticut Children's, and she also oversees pediatrics at Danbury Hospital. She called to say she would be happy to see the baby at the center once a week because she's in Danbury once a week, and, you know, be able to help in any way she can. And so we started talking about this task force. She's like, this is great. Ask for, you know, the big grand star, and hopefully you'll get something close to it. And I said, but what do you see the reason for, like, regional hospice who does pediatric hospice and now bringing home the 7-week-old, we have 7 children on our service. why are we not seeing more? if There's such a need for hospice. And she said, the families that I serve don't want to go home. The families I serve are petrified to go home with their babies. They have a lot of genetic anomalies. They don't want to be dealing with ventilators at home. They don't want to be responsible for giving medications. They just don't want this happening at home, which to me was like, okay, so wait. So there are a large number of patients and families in hospitals today that want to die in the hospital, and the hospital would like them to be on hospice. She said, the worst day of my life was when I got called in to pronounce a baby. She's like, I don't pronounce babies. Our caregivers here at the hospital are not comfortable pronouncing babies. And the family should be able to have the benefit of bereavement for the year after the death, which they get with hospice services. So as most of us know, we've been saying, well, to do hospice in a hospital setting, you have to be general inpatient level of care, which this 2-week-old with an unknown that she was going to be born with trisomy 18 does not qualify for GIP. So there she would be now if she's in the hospital in Montefiore. Obviously, the family wants to come home. They live in Washington, Connecticut. But even if she was in children's and they were afraid to take her home, we couldn't service them because it's not GIP. So is that something, and I just throw it out there because we haven't discussed it to date, that we add to our recommendation?
So I would say 2 things. So Tracy, can I steal a page from your playbook on your healthcare workforce safety work group?
Sure, as long as you don't divulge what we're recommending.
Well, I like the last recommendation that you made.
Well, I think it's important because it's not a one and done, and there's so many complexities and answers that you haven't gotten. So the last recommendation is that the legislature allows the work group to continue through 2025 to submit a report, 2026.
Thanks, Tracy.
Okay.
Thank you. So what I'm hearing is that family members are afraid because they don't have support at home, and that in the hospital setting, they're around professionals that are confident, they know what they're doing, and the family feels comfortable there. So not that necessarily they would want to be in a hospital setting at that point in their child's life or, the end of life. It's just that, well, if I go home, I don't know what I will do because I won't have any support there. I won't know what to do, there's no staff available. And it's very likely that these hospitals have tried to find them home hospice services and they couldn't.
Right. So that's a really good point. So what you're saying is if there was good support at home, they could leave the hospital, go home with good support and be home. And what does the cost of good support at home look like compared to being in a hospital? And what does that cost of care look like? It's like when I think about my, if I put my imaging hat on and how we used to say, lung cancer screening for smokers. If you smoked this amount of years, this amount, we should do lung cancer screening to try and catch lung cancer when it's really small so that it's treatable. And insurances would deny, but because then you're at the point where we're finding lung cancer, it's not treatable, and now your care is taking so much more money to care for you. Why not do it? So that's a really good point. What's the cost compared to being home with full home care? And even if hospice came in at some point, right? If you're getting full home care at home and it can be transitioned into hospice at the right time, because remember, we need to build that relationship too, because that's another thing we hear from families. Then you could still get that bereavement afterwards, and you could still get that social work care and all of those things that hospice provides.
Right. So how do families know? So we all like choices. We're all patients, and all of us like to have choices. So giving families with a child who is receiving palliative or hospice care, how do we notify them or inform them of all the choices that are out there? That we have, I say this and I don't say this in jest, Tony Ann. It took me a long time to get home care and hospice because of the 3 levels of care and GIP. And I work this every day.
Yeah.
How do families, is there a toolkit out there or a guidance document that maybe this group could not do maybe, but make a recommendation that there needs to be something out there that helps navigate the payment system?
Right.
How do we?
So that's another good point, right? How are people, Melissa, what did we say on the drive up that you said, I had no idea about that?
I had no idea that I was talking to an ER nurse at Vassar Hospital in New York, and she had never heard of concurrent care for pediatric hospice. So if the medical community doesn't know, then no one knows, right? Right, so concur.
Well, Tony Ann had to teach me about concurrent
Right.
care on a
Well,
phone
it's
call.
the best kept secret
Yes.
anywhere, so.
Yeah, may I add?
Yeah.
Tony Ann, did you reach out at all to the Alliance, formerly NHPCO, because they had a pediatric work group subcommittee that focused a lot on palliative care, et cetera, and not so much on the hospice piece, but I think there may already exist some documentation or tools on levels of care, palliative,
Yeah,
concurrent,
that's a really good point.
and something that would not need to be recreated.
Right.
But also the other piece of what you started with about parents being afraid to bring their child home and be at home. Did we ask Carrie from Massachusetts when she did her presentation? Their program is a pediatric palliative care program. Did we ask, and I don't remember me asking, what happens when the child becomes eligible for hospice? And how is it all managed? And can you give examples of what you've done?
So, Melissa and I forwarded it to you in your email, and I don't know that we're even going to get through it today. Met with Kerry because we did have those questions. Why is Massachusetts doing it so much better than we are? What does it look like? And how do we get there? And I don't know if, yes, Jasmine.
Go ahead, finish.
No, go ahead.
Well, I think we asked her how were they able to kind of maneuver, and it's because it's state funded. And it's
State
not,
funded.
it's not under
Right.
federal authority. So they do have a lot of flexibility with the way that they can administer that program. So I would assume that the children would still continue to get the services after they transition to hospice care, because they do have patients that are on for years.
Correct.
So
They
they
also mentioned that most of the kids are covered by Mass Health, so they're under the same insurance.
Right.
fund, right? So it's
Yep.
easy for them. And they have a very comprehensive and generous health system in Massachusetts too, that not everybody has the luxury of.
And it's grown over the years. I think they said now it's around 10 million. the
Yes,
state
10
share
million.
That they get.
Yeah, and I remember her saying that they've had some of the kids on caseload for 9 years. But I guess that next question is, okay, 9 years might be stable and chronic and stable kind of, and not really declining. So therein lies the question of what are the next steps? And I know that Carrie talked about their potential legislation or talk about legislation to further define some time limits, if based on a definition that someone would have to qualify. So if someone remains chronic and stable for a set amount of time, should they still be receiving the palliative care? And if they should it be limited to fewer visits than what they're now getting? I don't know. I'm just kind of looking at it that way. And then for those that are not chronic and stable, but are showing decline and need for eventual hospice, how are they managing it? Do they have some good information tools that would help the parents navigate through how they, how they would address it with the family.
And I think that's part of what we've been charged with also, is coming up with the funding and other things for all the levels of care. So I think that is another good point, but I like where you went with the recommendation of allowing the task force, the work group to work a little bit longer, because I think that may be a recommendation that, that we might need, because there's a lot of different parts to this, and that was one of the things that I was thinking about this past week. Maybe we need it to be, okay, maybe chronically ill looks a different way, right? And chronically ill can always, can turn into terminally ill, right? Chronically ill can stay chronically ill for a very long time, but at what point, what triggers what service? And at what point I have a kid that's been on service for 4 years. He's been on hospice services for 4 years. There's no improvement. There's little decline, every time, little decline, but he has concurrent care. So these are the things that I think have to be figured out. So the kids that maybe can be on palliative as opposed to hospice, or are chronically ill for years and years and years, I'm not sure at what that becomes, but where is the biggest spend, and at what time, at what point are you hitting these different triggers as a kid? So I think that's a great point that we would need to figure out.
Tracy, I don't see any guidance document from an HPCO, but I'll look further.
Well, I'd have to do a little research. NHPCO merged with NAC, and they're now the Alliance. So I'd have to look to see.
Well, but I think families need a roadmap.
I think with any good initiative, you need a media plan, which includes the roadmap, includes the details, it includes a lot of definitions, so that everybody, whether it's family or the medical practitioners or the hospice organizations, they all kind of are on the same, they're all singing from the same song sheet, right? So everybody has the same understanding. And that's a big deal, but yes, as you work through all the details, that can be translated into, here's what we need to do, here's when we need to release it, here's who our target audience is, here's our stakeholders, those types of things.
Did we talk about having like an excellence center? I believe we did, in which like training could occur.
Yeah.
That center could also be there, like advocacy and support for families.
Right.
With that roadmap.
Right.
For the family cause, and almost like triage, where you get a case manager or something to help the families navigate.
That's,
Could be, like,
yeah, no,
also
that's-
helping providers, but helping families.
right, right. I think too, when I think more about the Massachusetts model is, and Senator Anwar and I had talked about this, about regional being a center of excellence for training nurses and whatever. I almost see it as there's a state center of excellence that is running this do you know what I mean? Like Massachusetts, it's one entity that is really running this, and the referrals get fed down to the agencies that are providing service. But there's some, I would see it at, because, regional is one agency. I'd love to be able to be a center of excellence for nurses, but I don't know that we could train the amount of nurses and everywhere that they would have to be. There would have to be other, involvement in that, or is there a state run, whatever that looks like Perry's, they have a state run agency that oversees palliative and hospice care.
Or do you train the nurse educator that trains the nurses at the places instead of every single nurse?
Right.
Possibly. And then what I'm hearing you say is similar to like the CHW Association, like where they work, I believe, closely with, I think, OHS. And then their services kind of get trickled down. I mean, that could happen, but that sounds like it wouldn't be funded.
Yeah.
I think it would be a great idea.
Yeah. Yeah. What do you think, Tracy? You see a lot of,
You're on mute?
you're muted. You're muted.
Sorry, I just sent an email to my colleagues across the country to see if anybody has any kind of a guide that explains the various levels, including concurrent care. And, kind of timelines as to how it's shared, when, where, how, all those pieces. And then I was going to reach out to our national organization to see. So I kind of missed what was recommended.
We were talking about how, like, center of excellence to train. Jasmine had said maybe a center of excellence that trains the trainer. But we also talked about there being, like Kerry has, a state-run and funded agency that is running pediatric palliative care and hospice, and then sends out the referrals to those agencies that provide the service. And it's actually, I mean, I think it would have to, well, it wouldn't have to be like billed, and that would be up to each agency, but actually runs the service and then feeds it down to the agencies that are.
And who's funding that, Leanne? I know we
The
included that
state.
in the palliative care report, but who is this? Is it
For
DSS?
Massachusetts?
Oh, Massachusetts.
Yeah, yeah,
Oh,
yeah.
I thought there was something in Connecticut.
No,
Because
that's-
Kerry,
Maybe we
Kerry
should.
Moss, we included in the palliative care report, we made a reference to the work that she's done with the pediatric,
Absolutely.
group there. But I didn't really realize it was funded, but it's not funded.
Yeah.
The Massachusetts one.
Right. Yeah. I mean, you think about, right? You think about each agency and its decision on not providing pediatric hospice or pediatric palliative care, and why. And how, without the funding, how are these agencies then going to provide the services? And, at the end of the day, Melissa was in my office the other day and she kept writing on a piece of paper, and in the middle of the square was child. Like, we keep coming way out from how are we going to do this out here, and we have to keep coming back to what does that child need at the end of the day. So I think we just hit on another huge thing, right? So we know what it looks like now in the state of Connecticut. We know what we would like it to look like, but then how do we, like, number 3 here, evaluate payment and funding options for pediatric hospice care and those levels of care, and make a recommendation for that, which is more work. And I mean, maybe somebody does have the guidelines for it, but it's also about educating our physicians and our clinicians, because I could speak to a pediatrician who will say, you want me to estimate the trajectory of this patient's disease, and I'm not going to do that. Yet I'll talk to Kristen, an APRN, who says, I put it right on the line. I tell them exactly what I think, and we talk about hospice right as I'm talking about the care that they're going to be receiving as an intervention. But I'm able to have that conversation and say, if nothing was done at this time, I believe your child would not be here in 6 months. But that may not be the case, because they're also going to be doing treatment. But you have people that will have that conversation and understand hospice, whereas others are thinking that they're being, psychics, and I can't tell you what the, so I think it's a lot of education on the clinician's part too.
So in the Senate Bill 1, where all the safety information was housed for home health, there was a section in there about safety grant funding, that DSS would set up grant funding for safety initiatives, and then there was some money set aside in the budget. I'm just thinking, that might be one way. I don't know that you're going to be any have any success this year on anything like that, but
Right.
if there's some kind of funding, you capture what it's for, because to me, it's not just to provide that care, but I'm hearing it's also to provide the education to those providing care, whether it be the healthcare practitioners, you're talking about the physicians often in your discussion. So I think there needs to be education to the community, education to the healthcare providers, and um, and then the care itself.
Right.
And I can't tell you what kind of dollar amount to even consider or how people would qualify. They'd have to come up with a process showing need, showing intent, how many staff they would have, what kind of coverage area they'd be willing to serve.
Right, exactly. So how, I know you mentioned this, Tracy, and Barb, you guys just talked about the recommendation of extending the workforce for what you're working on. So how does that happen? That goes in the actual recommendation itself, or does that happen before the recommendation is due?
Well, for this year, we actually asked for a 1-month extension, and the co-chairs of public health granted that to us. But the recommendation to extend the work group for another year is going to be in our report.
There are two concepts there, then.
Right.
You could reach out to Senator Anwar and Representative McCarthy-Vahey and ask them.
Okay.
If you can have, March is, I think March is written in the legislation.
March 1.
Yeah, but you can make that request as Tracy co-chairs that work group.
Right.
And ask for an extension on that. And then, as Tracy has indicated, and their report's only in draft, but it's memorialized.
Right. Well, and I'm sure, Tracy knows, and maybe others. I just found out, I actually just found out the other day when I was with Tracy at a board meeting that they put forth a bill to mandate the recommendations of this work subgroup. So,
it's a placeholder.
yeah.
It's just a placeholder bill.
Yeah, but I want to get this right. I want to put the time into it that we need to put into it. So I think I will reach out to Senator Anwar and Representative McCarthy-Vahey and just let them know and, consider that we need an extension.
And then
more.
And then as Tracy has indicated, it's a placeholder.
Right.
And then that moves forward with recommendations. And then all the state agencies that could potentially be impacted by that, then poke at it.
Right.
That,
You still would need to submit a report
yes.
on your
Right.
due date. Yeah.
Right. So I guess the question would be, if I reach out to them and the answer is yes, we're still giving a report on March 1st, that would be not.
No, you could get the extension on the report,
Oh, okay.
right? Right
Okay.
here? Yeah.
Well, yeah, I think you have to be careful.
Yeah,
Peter,
no,
you
okay.
probably know when the deadline is for, I know they have a placeholder bill,
Yeah,
but
it's like
mid-March, right?
mid-March, I think it's
For
the
public health?
15th or the 16th.
Yeah.
To get their bill, so that's why the March, because I was like, why March? And it gives them time to take the recommendations.
Right.
Into bill form, kind of.
Oh, understood.
Are we working with a fiscal year commitment in terms of money as well for the state? For the March
But
one?
the state agencies would do their own fiscal impact.
Okay.
So if the recommendation number one was that DPH will buy a van to go out and visit all children with pediatric hospice needs, we would give you a price. I'm making that up.
Right.
A price, the fiscal note would be the price of the van, the price of housing the van, the price of, if it's a detailed, broken down fiscal note that this is what it's gonna cost DPH to do that recommendation. And if I'm making this up, something,
Yeah.
we support this work so much, so I
Right.
don't want to sound bad.
Right,
But we would say, in order for us to do that recommendation, we would need, I'm making a number up, $50,000.
right.
To do that.
Right.
And then that's done, that goes to the group, and Peter, you help me here, because you're the expert here, for consideration. That can we give? And I will openly tell you that sometimes nobody cares what it's gonna cost.
Right.
It just
Right.
still passes
Right,
and
right.
you do it.
Right.
So,
And I'm just asking from a report format, because I'm assuming I'm gonna do a little bit of work on this. Does it have to be kind of pulling at your heartstrings type of thing, or is it data driven, or a combination of things?
Yeah,
Well,
I think-
I guess what's the best way to,
I think data.
to get things
I think
over?
they love
I think
data.
both. I think data is
Legislators-
really important.
You need to have the data to help support that this is a problem.
Right.
And it's not a one-off. One small child passed away
Right.
and couldn't get access
Right.
to care. I mean, that's awful, awful, awful.
Yep.
But legislators, I think, and Tracy, you do this a lot more than I do, and Brian, they wanna know, how big is this problem?
Right.
Yeah.
One time is too many in my world.
Right.
But Tracy will appreciate this. Wendy, when she was teaching me how to do legislation, used to have to say, oh, Brian, you remember Wendy? No one really cares what you think about this bill. Surely you think it's a great bill. How much is it gonna cost?
Right.
That would be wonderful.
Yeah.
Okay. All right, so I'll get that email out, but then I just have a couple more questions. So as we've been working on all this, does anybody around the table feel we should be looking somewhere we're not? Is there something else we should be looking at? Is there other data that's maybe somebody can get that would help to push this forward? Are there others on the committee that we should, pull in? I don't want to keep pulling everybody in every, month when, especially the legislators, and to sit and listen to us go around the table. But are there people that are on the committee that we should pull in that could help more, either with reporting, since it's a lot of data that we need? And are we missing anything? Like, are we?
So Dr. Moss she does heme onc. I wonder, do we have a sense as to how many children right now are, and no, I want to withdraw that, because I'm thinking not all children who have
I know what you're saying, Barb, but we've used that data before when we're trying to promote with the legislators, the problems with placing just the complex care kids back at their homes versus leaving them in the hospital.
I don't want to make a presumption though, because
Yeah, you can't.
a child that has a diagnosis of cancer is gonna die. That's awful.
If you think about the definition of life limiting, which kind of goes back to it, is that a life limiting concept?
Palliative care is certainly a number we want to know, because that, as Tracy and Tony Ann have also indicated, children are on 8 years on service with palliative care. That's great.
Right.
Those are things that we celebrate, that child had 8 years of services.
Right.
To improve the quality of their life.
Right. And then also to be able to say, like, when I think of, the one kid that's been on hospice with us for, going on 4 years, although he fits all the criteria, if we're going to be looking at what we're spending and where the funding is going, should he be on palliative care now and not getting 2 visits a week or 1 visit a week and getting palliative care visit and, like,
What's the difference?
you have to be fair. At what point do you say, okay, this is hospice services that they're being paid for, he's in year 4, maybe, or do we level off actual hospice, right? So they're on hospice, and this happens sometimes in families anyway, and we're getting a certain amount of payment, and the nurse is going out and seeing him at least once a week, then the social worker's going out. Do we at some point say, okay, he might still be on hospice and that relationship is there, but we're going to make it a lower level of hospice? They don't need a visit every week. They only need a visit every month. And even though that could be considered palliative, if they're on the hospice, it still gives them the after death. Like, why not just, I don't know, it's almost like putting palliative and hospice together for pediatrics, and it's just different levels of visits that, get paid.
So I have a question, and I'm just wondering, I think at one point we were thinking about looking at the California system, and I don't know, is it still on our agenda, or so where does that go? And my other question is, whatever our recommendations are, can we start by looking at, doing a pilot somewhere?
Yes.
You're reading the report.
Absolutely. Absolutely. And that's what we were thinking too. And what we were going to talk about doing a pilot today, and then it came up the different levels of care and the funding for that, and how do we pay for it, and so now it's like, okay, so now what are we piloting, right? And what should that look like? What should a program look like? What should champion care look like? Whether you want to call it hospice or palliative, champion care can determine how many visits the family gets, what level of care they should get. Does it require also a home care nurse? And, that hospice, again, nurse or involvement, so there's relationship building, but what do all those different levels of care look like?
I have a question.
Right.
Go ahead. For those of you who have implemented new programs, have you ever recommended a pilot? And if so, how was it received?
We did a pilot with Moles in the early days. Remember Tracy? The Moles pilot.
Forms that
It was done with Wyndham Hospital.
And if you went to the assembly to petition to get funding for whatever, I mean, do they like pilots?
That part that was in like 10 years ago, 15, so I wasn't involved as engaged as I am now with Moles. Brian, do you remember what Wyndham did with that? Did they get? Tracy may remember as well.
I don't remember.
But it started out in Wyndham.
Yeah.
And then we expanded.
Yeah, usually with a pilot and having it legislatively, right? It's a champion within the legislature who will say, and then it goes in their district. Now, whether or not the need is there, then that's another problem. So you could have a champion who wants it in their district, but the need isn't there. And then what good is the pilot? Especially when you're dealing with a smaller population.
They're doing pediatric hospice right now in the responses. So look at that.
Wait, say that again?
8 responses.
Oh.
3 of the 8 are currently doing pediatric hospice. I expected to see 0. I truly did, so.
Well, I know we're one of them.
I'm one of them.
Oh, okay. Yes, okay.
We hit send right away.
Yeah.
But,
Yeah.
So we've talked about like funding for this care. Are we not going to then go through their insurance? And you said earlier, this little baby, the insurance wouldn't cover the inpatient. I have a patient on right now, their insurance would only cover 30 visits. So I know I prior worked in Massachusetts, and Massachusetts has required any insurances in the state to have a hospice benefit.
Yeah, we need to go there.
Yes, I'm just wondering, like, is it all that the state's gonna fund it, or is it that the state will supplement what insurances will do? So I think the funding piece really should be included.
Absolutely.
So I kind of wanted to back up, I guess, a little bit for you, but I would assume that it would be, covered by insurance. But then there's also the piece that it's not that just about whether or not they're covering the service, but can they be rendered? Because it's so complex. Like as far as training, you have to be specialized in hospice and in children, and then but they may be in a rural area where you can't get to. So there's a payment issue, and then there's also the access issue. So I wanted to talk about the pilot a little bit. I have been involved in some of those, and I guess like you were saying, it really depends on the need.
Mhm.
You have to kind of stress the need, and data is always great. I was going to piggyback off of Regina about looking more in depth at other states,
Mhm.
not just the two, and seeing how they determine level of care. Do they have some of these services involved in waivers? Like, how are they paying for them in a sustainable way?
Mhm.
I think Massachusetts has a lot more available funds to do that than we probably would.
Yeah.
So just pretty much looking at how they render hospice, palliative, different levels of care, are there fares?
Mhm.
There's other states, obviously, you have 40 plus more. But then some of them may also have done pilots as well.
Right.
Where we can say, the pilot that we done, it was a randomized controlled trial somewhere else. And it wasn't necessarily a pilot, but there was a portion of it that was evidence-based. So that helped with a lot of stakeholder engagement. We slightly twisted the pilot a little bit and added on another piece that was also had a lot of evidence behind it. The two didn't have evidence together, but separately they did, and there was a need for those services after COVID. So those are something,
I think that would be great, and we can. Tracy, do you have do you have a contact in California, or was that?
Yeah.
Yeah.
Yeah, it was.
Oh,
Yeah.
okay.
I thought about
California's a little busy right now with all the fraud and abuse issues going on out there, so I think it might have fallen down her list of priorities a bit.
Yeah, I'm sure. Well, we could always, I can just look into exactly, there's a lot of, information out there.
I'll engage her again. I'll text her right now.
Okay, and I can also do some research on that, but I think also it was Washington that
Yep.
it actually combined palliative and hospice, I believe, with a spa, help me, Peter, what's a spa?
Take the plan amendment.
Yeah.
There you go. So.
Been around too long.
Okay, no, so we'll look at, so I think we're gonna need a little bit more time. I will take that with, Senator Onwar and Representative McCarthy-Bacon, but I think we're in.
I'm not sure they're gonna give you a lot more time. March 1 is it's gonna be tight for them.
Yeah,
I'm thinking you need to start putting together a draft and see what we think we can come up with for recommendations.
right.
Right.
So we identified the gaps, barriers, problems well enough. We know that it's staffing. We know that it's funding. We know that it is access, but is the access, what's the problem with access? Is it diminished access because we don't have lots of providers that are doing it? Or is it because the providers don't have staff to do it? Have we identified that?
Well,
Problem well enough?
I also think there are providers that don't do it because it's too expensive. They don't make money.
So that would go under the funding. Are there any?
It's workforce and training too.
Are there any regulatory barriers here?
Well, that the hospice agency has to be home health. That's how we make it.
Well, we're taking care
Oh.
Yeah, we've done a lot of work on that one.
of it.
I think it's,
No comments from the peanut gallery.
You notice I averted Tracy's face.
Yeah, but Karen's in the room. You can look right at her and deal with it.
I think it is workforce, but it also is, just, they don't have the training, they don't, it's not
So,
something people are.
Do we have a recommendation around workforce? So I will tell you, when Karen and I were doing the palliative care report, I don't know if you've seen, I did a graph or I did something, and I was woefully unsettled we only have 14 pediatric palliative care certified nurses, and Karen is one of them. I was so unsettled with that. What do we need to do work with that?
We can talk about some limitations to our report, further time is needed to dive into these topics. Time is a limitation, so I think we're not able to be limited. More time.
Yeah, it is, I mean, you wonder, sometimes you get a rock star who has done pediatrics and has never done hospice, and within 3 months, they're doing pediatric hospice, like, but those are very few and far in between. So it's not only, okay, yeah, we'll be a center of excellence, but how are you getting those nurses to us? How are we finding those nurses that are interested in pediatrics, interested in even doing a rotation through hospice, like end of life, especially when it's pediatric hospice, and that comes through what Senator Anwar had said to me, which is, well, we're going to need to incentivize them.
And then the home care experience too,
Yeah,
What's
so-
that?
the home care experience as well.
Right.
You may have somebody interested in that type of care, but may not have ever done any kind of home health before.
Right.
That's the barrier we're having.
So is that a regulatory barrier? I don't remember,
Well,
it's not,
you kind of set your own, what you
No,
want.
it's not a regulatory, it's,
well, we have requirements for the executive director and the supervisor. But, and then I think the local agencies set their own requirements that you have to have 2
Yeah,
years.
that's what we set our own, and there,
I think so. I couldn't go to a home care agency and be a home care nurse. I don't think I could.
yes, you can, you just can't be a supervisor, manager level. I'll train you, Barb.
So we have a group of nurses at Yale Children's that want to follow their patients into the community. So they wanted to kind of come and be under our umbrella to be able to go out and do it. So we're just looking at, making sure regulatory, but the training that they would need. And then, there's the whole thing about, well, they need a case manager. Are they the case manager? So there is an interest out there, they were like, there's 20 of them that just really want to start. Yeah.
Just at Yale.
Just at Yale.
So how do we build programs like that, working with Brian
Mhm.
and his group?
Yeah.
So that Hartford's doing it. I bet Hartford wants to do it. They're on.
Hartford's working on a program, yeah.
Maybe
Ross is on this group, right?
okay.
Best
This is where you bring
practices
in
and
partners and help with this. And how do we build this workforce? And here's what I'm gonna say, without a lot of money.
right.
We don't have a lot of money, so how can we be really, really creative? And you have a model.
Yeah.
You got 20 nurses.
Yeah.
So how can we replicate that model with Brian and the CHA team and bring it there? They have work groups for every single discipline at CHA, and they're great to work with. They are.
So what does that mean? So you have 20 students that are in the nursing program.
No,
No.
this is Yale Children's Hospital. So they're
Oh.
registered nurses working in the hospital that want to be able to have some continuity with the pediatric patients they're looking after when they go to the community. And then they have that pediatric experience. So, it's a nice continuity of care.
Do they want to train in pediatric hospice? Do rotation in it?
That's what they're doing.
So they would
basically
be following
pediatric
them.
Out of care in the hospital. They would follow them out. We would train them on hospice, but it's just the,
Right,
they would
right.
need the home care.
That could be a
Right.
recommendation.
Yeah.
Yeah.
Is it, to me, grant funding?
Yeah.
We'd have to have somebody searching for
For what?
available funds
But what do we need money for?
for the training. And, you talked before about, what did you say, only 14 certified in the state? That all costs money.
See, that could be the.
Well, that was, and those individuals, unless their employer paid for it, but
Right.
we don't have money, stop me. I can't cave to
Yeah.
that.
Yeah,
just
no, well,
can't.
that's not, we weren't asked to find the money.
We find, and money is.
No, you're just asked to make the
Oh,
recommendation.
yeah, right.
It's wonderful, but if we can't get the money, how can we do it?
Well, they will find the money more.
They need
put
to
it in
find,
place
yeah,
and
somebody
say,
needs to find it.
Yeah.
Right, legislators will say, look, you guys have this amount of time to do this.
Right.
But I think the other thing is we have to be creative too.
you know,
see what already exists in the
community
and how we can collaborate
Right.
And there's who knew, Karen, you were doing that?
Right.
There's lots of good work that's
Yeah.
happening across the state that we don't even know about.
So those could potentially be, let's just say in the perfect world,
Mhm.
those could potentially be 20 trained pediatric hospice nurses.
That's amazing.
But from what I'm hearing from Karen, they don't want to give up their day job. Am I right, Karen? They want to fulfill and be per diem,
They want to.
like supplement.
Yeah, so that's why I'm like, well, if you're following the patient, you're really the case manager. You have to come to our IDT meetings and that's
Yeah.
sticky. So we're working through the minutia of it all.
So we need to watch that, then,
Yeah.
to see how
Yeah.
that evolves.
How can it work for them?
Yeah.
We do have the time on the floor, have the
Mhm.
time as case management.
You're gonna be the laboratory for that.
Absolutely.
And then, Tony, I see you being a center, a practicum center.
Yeah.
For people to gain the clinical experience. If you don't have the bandwidth
Right.
to develop the model, you're gonna be listen to me.
That's, yeah, our next governor.
Yeah, well, I was gonna say, you know I'm running against Aaron.
Wow, that's great. That's even good to hear that there are 20 people
Mhm.
in this state that are nurses that are interested in
Yes.
pediatric.
That's exciting.
Yeah,
Well,
that's,
the bigger question is, who else is out there doing the same thing that we don't know about,
What we
right?
talked about before, they make you, the nurses that are working in children's hospitals, they already have half of it, half down pat.
right,
It's the hospice partners that have to bring in.
right.
They're nurses, they work with kids already, so that's the hospice component, and then the home health, but
Right.
maybe if there's a way to transition, because like even Hartford Healthcare, they have the REACH program where the providers go out and attribute, individuals who are older in age who can't really make it to appointments. So like something like this could work really well with them. They have those providers willing to go to homes, they have the nurses, they have a home health.
And what's it called, the REACH program? I love that.
I do too.
Wait, and so what do they
using it so much, well, referring it. So, basically providers who will go to the home for telehealth of individuals who can't get out and they're like, I think 50 or older. And they also help with like care coordination, but it's called the REACH program.
And with Harvard Healthcare
Yeah.
Center?
Yeah.
Wow.
So like, there's innovation from Yale and from Harvard. And we have the infrastructure.
Brian's members are doing good work out there.
Trying. Yeah.
Have our excellences.
Well, and you think about too, like it's also, I forget who I had said this to, and maybe it was in the beginning, Dr. Moss. I said, you have to almost call it like pediatric hospice without borders, right? Because you have Hartford, you have Yale, look, and New Vance is soon gonna be Northwell, right? So you have you have areas of the state covered, and it should just be like, you're in these areas, you're doing this, like, you have to be helping to provide this kind of, care, no matter who you are, or, and then you have children's kind of in the middle there, but Yale's already, I mean, you guys with the 20 nurses, whatever Hartford, maybe could do for their area. It's just about taking care of kids in the territory that they're in. These are huge health systems. So, yeah, and we've been more than happy to like have people come and train, and I'll just say we have not had takers yet. Or I guess some people that are, interested. We haven't reached out to all the programs that are out there, but we have reached out to a couple.
Do you need to define kind of a curriculum for that? And I mean, a lot of training, obviously, for something like this is a hands-on focus, but are there some abstract, the book stuff that can be done virtually?
Well, we have one APRN that's coming to do training with us, who is bringing the curriculum with her. Like, these are all the things she needs, these are the hours that she needs, this is, but we're providing the clinical hours.
Is it an LNEC training that's specific to peds?
Yeah. Yes,
So the curriculum already exists.
correct.
Yeah, I would assume so, and I would assume that CAPSI has resources as well. So maybe it's really, I don't know if you've looked at any of that yet, but that's also what you may want to recommend as potential training resources that already exist.
Yeah, and then we just have to get Medicare to come down with the HOPE model so that we can keep people employed and not have to bring in
Yeah,
five.
well, that's not going to happen. I think you know that, Tony Ann.
Yeah,
It's all about more accountability, not less.
yeah.
So can I
That's gonna be a rough.
ask two other things? And this is actually a question for Peter, because this is a subgroup meeting. Do we need to meet with the bigger group to report off? And I'm not the best with complying with public meeting requirements. That's why I'm looking to you. Do we need to meet with the larger group so that we report off our work? Is there anything that we're required to do? Have we met as a big group? for a
We haven't
while?
met as a big group, but I did speak privately to some of the people on the other group saying, these are the reasons why we kind of have a subcommittee, and they were like, okay, because we don't have, we don't have a lot to offer, let us know when you need us. So I was thinking that February would be, the time for that, but I also maybe have that email and conversation before then, and then, see where that goes. Is it maybe, I don't know, April or something, do we get another date, but still bring them up to speed?
Okay.
Yeah.
And then the question of insurance came up, requiring a hospice benefit for all insurance providers. Are there people that aren't at the table that we need their expertise on? Because that's just the question
I mean, I don't.
Insurance is very, very, very.
Yeah, right, like this insurance that they were gonna pay 3 days GIP, and then anything after that, after they reached a $6,000 deductible, it was 50-50. Family's still paying for 50%. So, so how do you, I don't know how to deal with that. Is that at a state level? Is that at an anthem for the, I don't know.
I think
Is
it's
it a problem
It,
that we've identified?
Yeah,
that's a
definitely.
barrier
Yeah,
to
yeah.
access?
Yeah.
in Massachusetts, they legislated it that any providers in the state of Massachusetts have to offer a hospice benefit.
Which of those generally go like every year before the insurance committee, there's,
Yeah.
5 or 6 bills mandating certain coverage requirements,
Mhm.
which is always a big fight.
I just don't know if there's any other stakeholders that need to be, and I don't know, not a trick question, honest. I just don't know if there's anyone that's not here, a stakeholder that we need to consult, confer, clarify, I don't know. And if that were going to be a recommendation, is there information that we need to get from them?
Does that always have relationships with commercial payers? I'm wondering if they may be going.
With the commercial payers, I know what you're saying.
Mhm.
No, right up,
They're
The
immediately
concrete.
gonna say no.
yes. Can I just ask a question about the report back? If this is the subgroup to the question of should we have a meeting with the big group? I think, and I could be wrong, but doesn't the recommendation come from the bigger group? So we will have to,
Right.
okay, all right, I'm just trying to put the
Nope.
the cars in the right order.
Yeah.
And public meeting rules they're complicated.
Mhm.
For me, they're complicated. Probably for Peter, they're not, but for me, they're complicated.
All right, so I have an email to get out sooner than later.
And next meeting, Tony, and you tell us.
Next meeting, well, should I guess maybe let's put something as a placeholder. So can somebody just explain something to me, because I'm learning, a lot as this goes on too. When you say a bill was put forth just as a placeholder, what does that mean?
Want me to pull up the bill?
Oh, it's like a,
No,
like a short blurb where it's not legislative language. It's
okay,
a proposal, so like, it's a shell, so like a legislator would go to the lawyer and be like, oh, I'd like to put in a bill for implementing the recommendations of the pediatric task force.
Right.
Working group. So they make like a little blurb proposal, they submit that. On my side, I'd process that and put it in the public health bill record book. But then what happened is they'd first have to approve that stakeholder bill on an agenda, on a committee meeting agenda,
okay,
and then it has to be heard at a public hearing.
okay,
And then while it's recommended to the legislative language can be put in anywhere after the proposal, but like, what I feel like what happened is the shell will be heard at a public hearing, and then I feel like you guys will have the opportunity to come and give your comments, and then agencies will be able to come and give their comments. And then based on the response from the public and from backroom negotiations that I don't know anything about, they will, Senator Anwar and Representative McCarthy Beatty will talk to the lawyers and they'll write something in language, and you'll be able to see it then.
okay.
But
I'm gonna try to give you the
Because
bill.
certain
number.
deadlines,
Yeah, there's certain
there's
deadlines.
certain deadlines, they need like a physical bill with a bill number and a title that captures the essence of
Exactly.
what,
the pro-
the proposal will be, or an idea. So then at some point during the legislative process, they can just scrap that language and replace it with statutory language.
Okay.
So it's just a legislative vehicle to keep the idea or issue moving forward through the process.
So our the deadline for the shell is the mid-March.
Yeah, like the 14th or 16th
Yeah,
of
so we
March.
got
Meeting or for something else you're doing?
For the committee, for the public health committee.
Is it committee bill deadline? Like the 114th one?
I think it's bill 484
Subject parent committee bill deadline. Looks like this 16.
There's the one supposed to have to be online, so they're not gonna go online.
And that's when they meet with the committee, or is that the public?
No, the committee deadline, that's when the committee needs to have the bill fleshed out.
So they need all the
So
language in our
that's when it
proposal.
becomes a shell to a,
It's
Real thing.
it's a shell now, yeah, it morphs into something. a little
okay,
bit.
by March 16th.
So Tony, and this is what it looks like.
But if we're backing into that, our deadline to submit this to the stakeholders.
To the committee,
Yeah.
Senator Anwar
Is
and McCarthy Beatty.
Apparently it's March 1st.
March 1st, right, okay, that's what I thought.
Okay.
And Peter reminded me that there are two, which is not unusual for there to be multiple bills with the same concept.
So how does that,
They get married,
okay.
sort of. If it gets.
But there's not another working group working.
No,
on
no,
it, so
no,
you-
no.
No.
so this is way, okay,
It's fine.
yeah.
The
Devil's in the details, but, okay,
So, but at the end of session, that's not what it will look like.
No.
It'll be very, very substantive if it makes it out of committee and moves forward.
okay, so let's see, is everybody, I mean, depending on, but we should get something on the calendar for February, right? What is a good day for everybody? Like maybe the week of the 10th?
Me too.
Oh, is Wednesday the 12th good for anyone? I mean, we'll do it on Zoom.
Not in the afternoon, it's not for me.
The state holiday.
Oh.
Oh, thank you.
The 11th in the early afternoon?
Holiday for the
The 11th for
I think
anyone?
it's president.
A little later, at the end of the day.
Okay.
Well,
It's
Peter
either-
said it was, or Brian said it was.
Well, how
Yeah,
early,
yeah,
Trace?
yeah, website. The 12th.
It's probably when the president's
We
day,
have
yeah.
two.
Are you okay for 2 o'clock on the 11th?
Yeah, I have a 3:30.
Two,
No, the 11th.
the 11th at, would be, at 2 o'clock?
I won't be available that week, but originally.
Come on, what?
I'll be in Mexico.
Oh, good for you.
Oh, yeah. Well, on my way there.
Just go send us photos if you're sitting in.
I'll fly you guys
Yeah,
up right from the ship.
Are you planning on doing all of these in person, or because I'm still would like to do hybrid? I apologize for all the problems.
That was on our end.
Good.
That's on our end, Tracy, my end.
We're good. We'll do it. I think it was nice to get together. I just love being in person. I just feel like the conversation flows better, but I know it's not easy to get to a common place.
We should have a second one after that, since everybody's here.
I think virtual also might work better for Ross and for Carrie.
Yeah.
The 26th is close to this first.
Yeah,
I can't do the 26th. We have a public hearing for the entire day.
okay.
Yeah.
So that's the 26th. The 26th, you said?
Yeah, February 26th. It was. I can adjust.
It also may depend on whether or not you can get a month extension for our actual report.
But we
Well,
can't because we have to have it in.
We have to have something in, even if they
Right,
say.
yeah,
you
so
can
that they
extend
can-
it, something has to be in, so
for
how about we
first.
put the house the 25th? Tuesday, the 25th? 2 o'clock too? Tracy's not saying anything.
I'm looking.
Oh, okay.
Gotta pull my calendar
I'm
up.
looking at us, but you're looking at your calendar.
Yeah, I can do that.
Okay, 2 o'clock, so that's good. Okay.
Also, is that a point you want to invite the full working group for to that one?
I'm afraid if we invite them to that one, I think we should invite them to the, oh, God.
When you have your large work group, and here, this is where I need your guidance. Does the larger group have to vote on the report?
It would be up to the coaches, but they can't, you'd have the ability to vote.
Okay,
But not required.
I don't believe
The
so.
two co-chairs could just put the report forward, obviously with all the collaboration. Okay.
okay,
But we would need to meet as the full group before the first.
Yeah.
yes. Okay. Didn't run too much over, only 45 minutes over. Sorry, everybody.
Nice work. Thank you, Tony, and for moderating.
It was really nice. Oh, were we supposed to have a motion to end the meeting? Okay, thank you. I get so nervous, I gotta look at you like, oh, did I not do it the right way?
I fail it miserably all the time.
Thank you, everybody.
Bye.